Hi everyone, and welcome to Methylomic Matters, the podcast in which we discuss all kinds of matters regarding the Methylomic Project, a large European research project aimed at enhancing the effectiveness of the medication in chronic diseases such as Crohn's disease, rheumatoid arthritis, and psoriasis. And this episode is especially made for patients with rheumatoid arthritis, or RA. My name is Shula Tas. I'm a journalist, and in this episode we will discuss the EPIPSORA trial. That's an important trial that, with the help of AI, aims to help determine which medication will work best on which patient. And it's a more efficient way than the current trial and error approach. I will be interviewing Marleen van Sande, who is a rheumatologist at Amsterdam UMC, and Frank van Empel, a patient with rheumatoid arthritis. Welcome, both of you.
Thank you.
Thank you.
Happy to have you here. Marleen, can you start by the beginning? What is RA and how does it impact the lives of patients?
Yeah, so RA, rheumatoid arthritis, is a chronic inflammatory disease which mainly affects the joints. But in some patients also other organs can be affected. And this inflammation of the joints leads to pain and loss of function. So people sometimes move their joints less easily. And if the inflammation is not treated, it can result in destruction of cartilage and bone. And of course, if you have cartilage and bone destruction, this is permanent loss of function. So we always aim to prevent this by treatments, but in some patients this is not incompletely possible, and therefore often patients still suffer from loss of quality of life.
And Frank, you are a patient with RA?
Unfortunately.
Unfortunately, yes. Can you tell us a bit about how the illness impacts your life?
Impacted, because basically things are going fine right now, but basically it was one of the reasons why I decided to stop working on a professional basis in 2017. I was 52 at the time, so it was some impact, yeah.
And you decided to stop working because the pain was too severe?
I didn't have a physically demanding job, but it did involve some traveling abroad, and that was sometimes unexpected when you need to catch a plane, and you just have to walk a little bit faster, and you can't because your feet don't cooperate because you have an inflammation in your feet. Fortunately, I usually have it in the hands. Used to have it in the hands because right now it's
Going fairly well.
Yeah, in remission, is that an English word?
Yes, it's in remission indeed.
Arthritis in remission.
Yeah. It's an arthritis in remission, but beforehand it did impact you severely because you stopped working, so that's
one
a
of
big
the
impact.
reasons. Wasn't the main reason, let's say 30%.
Yeah.
It was one of the contributing factors for me to stop working.
And you say it's in remission, is that because of treatment?
Yep, yes indeed. The first medication, synthetic medication, was spot on. So basically...
I think Frank is one of those patients that do respond to the initial start of treatment. Unfortunately, we know that it's about in half of the patients. So some patients do not respond to the first line of treatments. So then we have to continue to second line of treatments. But here I think Frank is a good example that even when the disease is well treated and it's going well, patients can even still suffer from some pains, some tiredness. So fatigue is also for some patients still a problem even when the disease is well treated. So I think Frank is lucky. So he's now no joint swelling anymore and the pain is doing better.
Correct.
But it still shows that it's a disease that even when it's well treated can still impact daily quality of life.
And when you say well treated, how is it treated right now?
Yeah, so we have a standard scheme. So we follow recommendations for treatment. So people often start with what we call conventional disease-modifying anti-rheumatic drug. A lot of words, and as Frank said, it's a synthetic drug. Usually we start with methotrexate. This is our anchor drug. If patients have reasons not to start with methotrexate, there can be some. Then we have other conventional DMARDs that we start, but usually we start with methotrexate, and we see the effect and evaluate it after about 3 months. And then we decide if there's a good response or a good enough response, then we will continue. If patients are still having active inflammation, then we continue to the second line of treatments, which is usually biologic DMARD or a targeted synthetic, which are the new lines of drugs.
Yeah, and how often is it successful? Can you say?
Yeah, in about half of the patients, maybe 60%, 70% sometimes, but it's, I would say, half of the patients to 60% are well enough treated.
Okay, so it's a 50-50 chance.
Yeah,
you're the lucky half.
Yeah, I think a little bit more, but would say 60. Yeah, more or less.
And what is the Epipsora trial exactly?
Yeah, so the Epipsora trial is a trial where we want to see if we, by a blood test, can predict what would be the treatment effect when we initiate a certain line of treatment. So as we said, after failing the first line of treatment, we start with the biologic treatments or targeted synthetics. But we do not know which patients will respond to which drug, because here also about 2/3 to 50% of the patients do not have a good response to these drugs, and then you just go to the second one. So, and for the patient, of course, it would be great if you could beforehand say, this would be a good drug for you because we see in your blood profile that you will respond to this drug. And this is what we want to investigate, to see if patients have a certain profile in their blood that predicts how they will respond to a certain type of treatment.
So it's an observational study?
Indeed.
To develop an epigenetic biomarker panel, right?
Indeed. So
can you explain what are biomarkers?
Yeah, biomarkers are some markers that are in the blood, which can be proteins, or it can be a genetic or epigenetic profile. So it means that in your blood there are all these factors that we can measure, and depending on the factors that we measure, we want to see a response, and that's why it's a biomarker, to see if you can link certain factors in the blood to, it can be disease activity, but here it can also be treatment outcome.
And what is the predicament of how this will impact or how this will change the treatment of RA?
Yeah, so we hope, of course, if we have a very good profile biomarker panel that we can identify that really discriminates between patients who will and will not respond, then it can hugely impact, of course, because if this is a blood test that can be done before start of treatment, and then tell a patient this is a good drug, then we have the most chance of response, of course, because then we will have less patients who do not respond to the treatment because we know it up front. So I think this is a great thing. And there are other studies also investigating biomarkers, for instance, in tissue, but this is the advantage that it's truly a blood test. And blood is quite easily to collect from patients, easier than tissues. So I think it's really interesting if we can have a predictive biomarker tool.
Yeah, and this study is correlated with the trials for Crohn's disease. How do these relate? Can you tell something about that?
Yes, so of course Crohn's is also a chronic immune-mediated inflammatory disease. And we have overlapping treatments. So some treatments that are used for Crohn's disease are also used in rheumatoid arthritis. For instance, the TNF inhibitors, we see them in both diseases. And what they've seen in Crohn's disease is that indeed they could find this biomarker panel that could predict treatment response. And because similar treatments are used, we wanted to also see in another chronic inflammatory disease, can we predict also here the treatment response? So that was initially the start of the project, to have more patients, not only with inflammatory bowel disease, but also with other chronic immune-mediated diseases such as rheumatoid arthritis and psoriasis, benefit from this knowledge that was gained in Crohn's disease.
Frank, you are part of the lucky ones that are in the 50% where it 60 where it initially worked. What would it mean to you if you could get the right medicine right away thanks to AI?
First of all, I immediately had the correct medicine, so I never experienced it myself. But from what I learned from other patients, they've been struggling for methotrexate. It's not the nicest stuff to take on a Saturday because sometimes it does impact your stomach, and it's not really the side effects of medication is sometimes a bit disturbing for your daily life. So yeah, the proper stuff the first time, for me it worked great, but for others it's kind of a painful process.
Yeah, if it's not the right medicine, it can be painful as well.
You start with something like a methotrexate, and then you it doesn't work. It doesn't improve. It only gets worse, and the side effects are impacting your life. Well, it saves you some time.
Yeah,
I'd say 12 months at least.
Yeah, so it's really different. So I said if you fail the first line of treatment, you go after 3 months, you go to the second line, but then you have to wait again 3 months to see will it be effective or not. Sometimes even a little bit longer.
Yeah. And
so when it's not working, then you're already 3 months further down the road,
and you're still in pain. Your joints are still deteriorating. Yeah.
So that's the huge impact. So you have a long time suffering from pain and limitations, and then you go to the second one, and then you hope it will be beneficial, but also there. So yeah, and we have many lines of treatment now. So
fortunately,
yeah.
But picking the correct one which works for you as a person, well, that's personal.
Yeah, and that's still a challenge that we have to overcome.
Yeah. But you mentioned with the help of AI, and I always trust the instinct of a doctor.
Yeah,
I have to say this because my doctor's.
Of course, she's sitting next to you. Yeah.
But how do you? It's a nice mouth word, I think.
It's a good question. What is the role of AI in this research?
Yeah. So as you already mentioned, we're looking at epigenetic factors. Mm-hmm. So as we all know, we have in our cells we have DNA, and the DNA makes our body and cells that we make proteins, but the epigenetics are factors that drive and influence also which proteins are produced by the cells, to say it simple. And you can measure it in the blood, this profile, but it gives, like you have many genes, as most of you know.
More than 8,000, right?
No, genes even more.
Oh, sorry.
Yeah, and epigenetic markers, so you have a lot.
Yeah.
And then these markers you can measure, but of course you get a result of many factors. So, and to find a profile, we as humans find it very difficult if you have like 8,000 values or even more to calculate with. So there we use bioinformatics. It's a way of looking at data, and this helps us to identify a profile. And of course, there's some human influence here as well. So you have to think how you use the bioinformatics. So you do the knowledge, but it's also with the aid of the tool. And that's the AI, where the AI comes in. Okay. It gives us information on data which we as humans cannot oversee anymore ourselves.
So the data set is so large that humans cannot really calculate, and the AI helps calculate which will be the most effective.
Indeed, yeah. So that's where the AI comes in. So,
clear.
And there are many forms of AI, and I think a lot in the media is now on generative AI. So, but this is not data being generated; it's a way of like calculating.
It's a super calculator.
Yes.
Yeah.
I would say it like that. So that maybe gives a little bit more trust that it's not.
Yeah, well, I was a little bit skeptical about AI, because in my artificial intelligence, it cannot be more intelligent than the one who programmed the software. So, in my opinion, but again,
well, it is.
The way you explain it.
Yeah. Does it insure you? Does it make you feel more at ease?
It doesn't insure me, but I'm a little bit less skeptical about AI than I used to be.
That's
compared to instinct.
Yeah, good to hear. Can the results be incorporated into the pathway soon, into the care pathway soon?
Yeah, so that's always, of course, and it takes some time, because first we have to, and that's what we're going to do in this trial. So first we'll see, do we find the profile that's predictive? And then, of course, you have to see, when you apply the profile, is it better than what we are currently doing? And that's what they're now investigating in Crohn's disease.
Yep.
So they're really implementing this. But first you have to prove it in a trial that it's really an advantage. But then when that's shown, then of course the next step can be done to really develop it for use in the clinics. And of course, there are also challenges to overcome. It has to be measurable. The costs, of course, are always important. Is the cost benefit good enough? But I think with blood tests, we're very hopeful for that. But so, yeah, I think it is.
Is it a
some
matter
journey?
of years?
Yeah, I would say.
How many years, if you can
Yeah.
pin it down?
Yeah, it's always a tricky question, how many, but within 5 years or something, I think it could be feasible.
And how do you see the future for the treatment of RA specifically?
Yeah, I think there are many efforts being made. So this is one of it, on really improving the treatment outcomes with implementing tools that can predict treatment response. And I think we can get there. And especially because I think in the past it has been tried a lot to predict response to treatment. But now with the new techniques that we have available, such as the bioinformatics, which we named here AI, I think that made us possible to use a large set of data to predict. Because what we know is that we have one single factor that's usually not good enough, because each patient with rheumatoid arthritis is a little bit different and there's so many factors that influence it. So we have to have a huge set that really helps to predict. And I think with the new techniques, we can get there.
And if you participate in this study, what exactly does it mean for patients?
Yeah, so now for patients, they get their regular treatments, which is just prescribed by their treating physician. And what they are asked to provide a blood sample. So one blood sample is being drawn before they start the treatment. Then we see what the disease activity is, but that's usual care. And then, according to usual care, they're being followed for 3 months, and we measure again disease activity after 3 months. So the extra what they will do is just the blood sampling in the beginning.
That's the only difference is you take blood of them beforehand.
It's not a real difference, because each 6 months I have to provide 2 tubes of blood anyway for the regular consultation.
So it's good to mention, because indeed it's combined already with the draw of blood that has been done anyway. So it's not even an extra puncture that the patient has to undergo for taking the blood. It's just one tube that's extra collected, which makes the trial much easier to implement.
Would you want to participate in this, Frank?
I would have no problems with it, but I'm not quite sure whether I'm the correct person, because I already have the proper medication and I already went through the process. So I'm not sure. Yes, I would be willing, but I don't know if
you qualify. So I think at current time,
if I can attribute to anything.
Yeah, at the moment you would not qualify because your disease is not active. But as you said, I think that's important for us to know as well. Like, would you this kind of design? Would that be something that you think that's not too much of a burden for me as a person? I
said, I already provide blood on a semi-annual basis anyway. So and for another patient would be the same burden.
Yeah. There are 3 countries who are part of this trial, namely Portugal, Belgium and the Netherlands. So if there's a patient listening right now and they would like to participate, can they sign up for the study and where?
Yeah, so I cannot speak for the other countries what would be feasible. For us, patients can contact us in the Amsterdam UMC. It would mean for them that they would have to come 2 times just for research to the Amsterdam UMC, because then we would have to see them and at least get some information about the disease activity and blood sampling. For now, we're mainly performing it at the Amsterdam UMC, and we have patients here. But of course, if patients are listening and are thinking I'm very interested in research, they can always contact us at Amsterdam UMC. The email is KIR at amsterdamumc.nl. And if they're interested in participating in research, they can make it known here, and then somebody will respond. So that's always good to have people who are motivated to participate, because I think, we need numbers, and this is some of the projects. But of course, it's also people would have to travel. So maybe for people living nearby, it would be a great opportunity. But we also had in studies in the past that people from all around the Netherlands were willing to come to Amsterdam to help us improve the care for patients. So, but it really depends. So, but
Any preference in gender and age?
No, it doesn't matter. So, but people have to have actively starting a new biologic. So there are some questions before we can give it a go. So that's
I'm out.
so that's always the important
so
stuff.
the best thing is to ask your physician and then they can
No, I think if you're not
you.
being treated in the Amsterdam UMC and you are you have rheumatoid arthritis, you are starting on a new biologic, which is either, because we only have 3 preferences, so adalimumab, tocilizumab, or abatacept, then and you are willing to participate before you start the treatment, and the window, of course, is also for some patients not that large because they want to start treatment in a short. Yes. Yeah. So, but then you can contact us, and we're happy to see if you will qualify.
Okay. Thank you so much for your expertise and your time. For more information about Methylomic and other podcasts, please visit methylomic.eu.